Your genes hold the answers to your family's overall health. I'm Dr. Paula Krupstad, and on the Get to the Root with Hope for Healing podcast, I sit down with experts in genetics, functional medicine, and family care to explore what's really going on beneath the surface so you can stop guessing and start healing. From personalized insights to practical tools, we bring you whole family wellness that starts at the root. Welcome to part 2 of the Get to the Root podcast on pediatric dentistry with Dr. Amy Luedemann. Welcome again, Amy, and I'm going to let you explain to the listening audience what your credentials are as far as airway medicine goes, because that is newer. And now I would say all the pediatric dentists that we're exposed to, we're starting to see that not all, but many of them are exposed to it. And it's like, if they're not, it's like you're missing a huge piece of caring for a child. So would you explain to everyone what airway medicine is?
Okay. Well, I would say that in general, in my training and my contemporaries, we really did talk about airway dentistry at all. I think it was in 2018 when the ADA had sort of a conference and basically at that time mandated the dentist, since we were seeing patients twice a year, and many patients weren't going to the doctor near as often. Once you don't do your annual visits as a child, just lots of things happen and the pediatricians and the physicians were not seeing it. So they said dentists need to be looking. So I think that definitely was a huge factor in why dentists started looking more. I can't really say what is taught in residencies, right now, but you're right. There's a much more of an emphasis on it. There's not a specialty like there is in pathology or oral surgery or things like that. So there's not a specialty in airway. um, I would say orthodontists, pediatric dentists, and some general dentists are now looking more at it. And just like a number of other things, the training comes after you get out, right? So it's as a dentist, you have an option to see what you're interested in. And right now, that's kind of the hot topic. But as far as training goes, I kind of this is a really passionate topic for me. I've been helping with children and airway probably since around 2000 when I first kind of became aware of it. And I hosted an interdisciplinary study club for almost 10 years. And the first number of years, we just focused on 0 to 6 month old. And then we moved 0 to 3 year old because I had a child die of SIDS in my practice. And that was a big eye opener for me. I'd only met the child once. So it's a very passionate topic for me. And in general, what I notice is that when people talk about airway dentistry, they're talking a lot about measurements. They're talking about a lot of interventions, whether it be from a medical standpoint, CPAPs or other devices to help like manually move the jaw open or do things at night to from a structural standpoint, help airflow, which I'm not saying should not be done. And then when we're talking about growing children, even adults, I won't go into adults because I'm a pediatric dentist, but growing children, I feel like there's this emphasis on the palate needs to be expanded X number, of millimeters, and this needs to happen. But airway for me is the whole person. There's so much more
Mm.
to it than the site. Because I've seen plenty of patients, I've been one myself, that have a tiny volume airway but a great nervous system, great tone, and they don't have a breathing problem. And I've seen people with big airways, the airways that are structurally big, but their nervous system is terrible and they're floppy and their airways are collapsing. So it's not just about size and structure, it's about the entire person. And you see a person's airway looking at them standing in front of you. You see their airway and how they hold their body. So airway is so much more, but I guess in answer to your question, there's a lot of courses out there that now teach dentists about airway, and they're talking about tongue tie. They're talking about palate expansion. They're talking about what dentists do well, which is look at structure and think about how do I modify that structure to be what I think it should look like for a healthy airway. And I'm actually teaching in Scottsdale early next year, and my course is when a big airway isn't enough. Because I think, as we'll see, as people are going through this learning curve of all these things, they get to a point and they're like, well, I did all this and I did the palate expansion, the numbers of this, and why is my patient still wetting the bed, still anxious and not focused in school, still mouth breathing all day long? Like, what am I missing? So I don't know if that was a great answer to the question, but
Yeah, it's a great intro because something you said in your first pediatric dentistry podcast was form
follows function.
follows function. Yes, and as I'm, visualizing what that means. So, let's go right to birth and I'll draw in a few things but I would like you to talk about what is a tongue tie and how could or would a parent know that that's an issue, whether they're breastfeeding, attempting to breastfeed, or formula feeding. So we're looking at a baby, we're comparing and contrasting, and what is it? What are they looking for? Because we have kids come into the practice all the time, and no one has ever recognized that they have a tongue tie or even a lip tie or ties on other parts of their tongue. And we still miss all these things. We defer to an expert like you, but how do you know? And what should a parent know, especially beginning at the beginning of life?
Disclaimer, I could really go off here, so I'm gonna try to
Okay.
follow a path.
Okay.
So first thing is when a baby is born, we now know there's some study out there. I have a lot of friends, like I said, they're osteopaths. When babies are born, even via C-section, but definitely via vaginal birth, there's something that is called occipital compression. And about 95% of babies have occipital compression, at least, if not 100%. And it's normal. It's the cranium sort of being squished to come out. The reason I mention that is because if you turn the skull upside down on a newborn, the occiput is not one bone until age 9. It's 4 little pieces. And the
Mm,
nerve that runs right through the occiput, that when there's compression is affected, is motor to the tongue. So I like to
mm,
mention that because, God, if every baby could get occipital decompression at birth, it would be so fabulous, right? But that doesn't happen. So now we're going to move into talking about tongue ties. I need to mention that though, because in the world of tongue tie, I think it's really important that people have a team approach. I hate cut and go because it just can create such a disaster. So, how do you know? Okay, let's see. So occipital compression is present, and the reason it's important if you think your baby has a tongue tie because they're not latching on well, they're having, there's so it's out there all over all the different things that you can have affecting your ability to latch. They're clicking, they're, taking in air, they're falling off, you can't get a latch. Like there's so many different things. But all of that can happen because the motor to the tongue isn't functioning well. There's compression,
mhm,
the other things. So it's really important to have someone that is skilled at looking at a baby from a functional and structural standpoint. Check that baby first. Because if you have a baby that has tongue dysfunction, whether it's from occipital compression or something else, and you go and do a surgery on it, the dysfunction is still there. And now the the tongue is still going to function the way it has been, and it's going to create a new frenum which is pretty much going to be identical, but now it's more going to scar tissue in. So it's really important that
mm.
someone makes sure that none of the functional issues are coming from that point of view. And please go ahead.
So people that can address that, you mentioned osteopath, but chiropractic body
100%.
work.
And
Okay.
so babies, basically we say form from the cranium down. So I only work with chiropractors that really understand infants and developing babies and fascia and are gentle. Babies and small children do not need their back cracked or their neck cracked because that's not where the issue is. They need someone that understands the whole system and is gently releasing the fascia and so forth. So as we've talked about the other things, we're meant to be in harmony and balance. So that's really important. Having someone that's, cracking little babies' backs and things like that is really inappropriate and not going to help the situation, in my opinion. So yes, having an
Yes.
osteopath or a chiropractor who's got the extra training in infants and who really works with this population and is working with the whole system, the whole nervous system, and the whole baby. And
Mm.
then having a lactation consultant. I can tell you why this is also important. A lactation consultant is amazing. I remember when my daughter was born, I had her 3 times. I was only in the hospital like a day and a half, but 3 times she was in there because I was like, "It's not what happened. It's still late, whatever." And I've had patients come into my practice that didn't have lactation or that had one that was maybe just not as skilled or whatever. And the baby had been green lighted from the body worker and the functional worker, which was the IBCLC, to have the surgery. We did the surgery, and it's like nothing feels different. So my IBCLC goes in the room, and she's like, "Oh my gosh." Like the positioning of the baby, the way the mom's latching, all that. She fixes all that. And like, oh my God, that's amazing. So IBCLCs do so much. And even I've had, babies come in with severe tongue ties, but with a really great IBCLC, they're able to do it to where it's so much less painful and effective. So you really need those two perspectives. And sometimes if it's a little bit older child or more complicated, there are speech language pathologists or occupational therapists who specialize in infants and feeding, and they can also help. My first go-to would be an IBCLC. So those are really important pieces. And in our study club that, did 0 to 3-year-olds, and we were talking about feeding and infants and tongue tied for probably 7 years, that's all we talked about.
Yeah.
Our study club, which is people all over the greater Houston area, said our goal before cutting a baby was that we had them functioning at the most ideal way they could be. Like everything was ideal about their body, their cranium, their function, everything else prior to cutting. That's the
Yes.
ideal. And then when you do the surgery, you can expect to have a great outcome in lots of different ways. And so, yeah, sorry, that's what I mean. It's a
Yeah.
topic for me. And it's like, it's not just about looking and going, oh, I see it. Because this is another thing. So we talked about
Yes.
babies in the last episode having born very retrognathic. Their lower jaw is very set back. Their mom probably had breathing, sleep issues at birth. That affects how their lower jaw grows. So when they come out, if you have a baby with an airway issue, the frenum is laying across the genioglossus muscles, which are,
So can you tell everybody what the
yeah,
frenum
so
is?
this little string, let's see, under the
Gotcha. Mhm.
so everybody has one. But it's that frenum is a little attachment that lays across these muscles that are airway dilator muscles. So if you have a patient of any age that has an airway as a primary issue at that time, and you just go in and cut the frenum and you haven't really dealt with the airway issue, that new frenum is going to form tighter and shorter, most likely, because it's more important to hold the airway open than the way you speak
Ugh.
or swallow. So it's really important to know that ahead of time. And sometimes you have to address some of the nervous system and all the other things related to airway. And because that frenum, so a true tongue tie is fibers similar to webbed fingers or webbed toes. So it's incomplete apoptosis. So when you're inside the womb, everything's like a little web. And apoptosis is when everything separates and those extra cells go away. And underneath the tongue, when you have a true tongue tie, which you can look at histologically, it's incomplete apoptosis. However, sometimes you can have a frenum that looks like endoglossia, but it's really just, you could think of more armored fascia that has something to do with the rest of the body. And one of the procedures that we would do in our practice, laser assisted functional therapeutic release, laughter, sometimes goes baby lace, oral lace, different things, but we're using a very specific laser that it can release the fascia onto contact. And that was a differential diagnostic tool because when I would use that, if I saw that frenum double or triple in size, like right there in the clinic, I'm like, I
Yeah.
don't think I have a structural problem here. And sometimes they would have an immediate, like, oh my God, breastfeeding was better. This was better. This was better. Do I need to do it? It's like, I don't know yet. But if it tightens back up, I know I need more people on the team because something else is going on here. Does that make sense?
Yes, very much so. So here's a question. If a parent has no idea that they may have a child that has a tongue tie airway issue, what would be the way that an infant might position themselves when they're laying down? Like let's say they're on their side. What would they look like to try to make an airway? That might be a clue.
Yeah. So in general, if you lay an infant down on their back, they should be able to have their mouth closed and breathe quietly. If that infant is struggling and, wiggling, crying, twisting, turning when you're laying them on the back, that's a pretty good sign they have an airway issue. That's not normal. I'm not sure if that's what you mean, but and again, you can have lots of more C shape, but that could not just be physical restriction, but it could be the tongue functioning as though it's restricted because there's dural tension throughout the entire baby, or there's, other things going on. So I wouldn't But, for parents who are watching this, they're like, I wonder if my kid has a tongue tie. I wonder if I should have my kid assessed for a tongue tie. I would probably start with an IBCLC and just assess how is the feeding, how is the function. Or if you go to your pediatrician or your pediatric dentist or someone else or your neighbor says that looks like a tongue tie, again, the thing for me is yes, go and have someone look at it. In Brazil, they have a law that they passed 2016 maybe. All infants in the first 48 hours of life have to have their tongue inspected, and they have a validated protocol. And the reason that is
Mm,
because in Brazil, like other countries, the government helps to pay for problems. Here, that's
mm,
not the case. So there is enough research, particularly a lot out of Brazil, that says if you have a tongue tie, here are all the things that you might have to deal with later from a medical dental perspective. So it's a no-brainer to go and have within the first 48 hours of life this validated protocol that's hundreds, now thousands and thousands of babies at thousands of hospitals. It's validated. So if the baby qualifies on that as restricted, they get it done. That's a priority. If it's questionable, they have to come back in X amount of time and do some things in between. So
mhm.
yeah, so I think it's really important that we have someone look at it. But if you have someone look at it, it doesn't mean like, oh, it's restricted. Yeah, let me cut it right away. Even if it's an obvious one, in my opinion, you need to do a little bit of work in the ways that we've been talking about before the baby's ready for a good outcome.
I'm so glad you unpacked that because I have grown so much more. I defer to that multidisciplinary team. And, we have a group of chiropractors in the area that do just outstanding mother baby dyad and chiropractic care. Like you were talking about the whole occipital area. Now, what you mentioned that in Brazil, they have the whole list of all the other things. I'm thinking of a lot of the other things that we tend to see. But what are the things that are on that list of potential challenges that a child that has a tongue that doesn't move appropriately? Would you just kind of go through that,
If your
Amy?
tongue is restricted, you cannot swallow properly. Of course, you'll be swallowing and eating, but you're going to have some type of altered swallow pattern. So, and your tongue is the driver of growth and development for the face, jaw, and airways. So, if your pattern of swallow is altered, it's going to show up in your whole face. So, you're going to have this kind of swallow pattern, this kind of swallow pattern as you grow, cross spikes, narrow, crowding, all that kind of stuff. And again, in the previous one, we talked about how the width of your face is the width of your airway. We could think of it like that. And in front of the spine, behind the jaws, is the depth of your airway. So if you have an altered swallow pattern, you are not going to grow forward and wide as you are meant to. So that's dental problems, all sorts of them that can come from that, and a variety of them depending on what you adopt as your altered swallow pattern. So cavities, periodontal disease, airway, breathing issues. And then altered swallow pattern and breathing issues relate to your whole entire system, right? So typically, if you have a tongue tie and you're not able to swallow properly, you're going to more likely be a mouth breather. Not 100% of the time, but the tongue is restricted down and it's meant to rest up, which opens up that airway when it's resting the right way. So when it's resting down, you're more likely going to be a mouth breather. And that creates a whole nother host of issues, right? Our nose is meant to clean the air as it goes back. And when we're not nasal breathing, we're more dehydrated. Our teeth are drier, more prone to cavities, our gingival tissues, tonsils and adenoids are taking on a lot of things that they might not otherwise be taking on. So there's all of that perspective. And then the whole body itself is kind of like you might have a shoulder up. You're going to, if you look, I mean, that's what all of our patients, we took certain pictures of them. And it's fascinating to see how the gait, would also take videos of them walking, but how their hips are aligned, how their feet are changed, how all of that has changed. And yeah, I won't go into what happens if you throw braces on top of that or expanders on top of that whole system that's out of whack. But those are some of the side effects that come to the top of my mind for untreated tongue
Yeah.
tie.
And I'll just say too, of course, if your sleep is impaired, then you have an epidemic of attention deficit hyperactivity disorder where all these kids and adults are receiving medications that it's their airway. There's Yeah, they're not sleeping, they're not getting anything quality.
Yes.
And then
And then
the
at nighttime when you sleep and your tongue is supposed to be pumping, lymphatics, you're not flushing the toilet at night. All of the neurotoxicity stuff that is going on up here because of the diet and the environment, everything else, that tongue exerts 500 grams of pressure on the palate on every swallow. We swallow a couple thousand times a day. And at nighttime in particular, that's when all of that's supposed to dump and it doesn't dump. And then food, I also forgot that, but like people who have tongue tie and can't swallow properly, they're generally not chewing the food as well. So they've got all kinds of indigestion issues, constipation issues, or diarrhea, all these other constitutional symptoms simply because of their inability to really chew the food and, even eat certain foods. A lot of them will, you can't swallow a pill, they don't eat chicken because of this or that. And there's like texture issues because they can't get it down because they can't swallow properly. So it leads to a whole bunch of other.
I'd like to thank Fagron Genomics for sponsoring our podcast. Without knowing what your precision genetics are, you don't have a roadmap. So please log on to our website, schedule a welcome call, and see what the Wellness Blueprint can do for you. That's the premier and proprietary genetic panel that Fagron has allowed us to create. Yes. And these kids who come in that have a lisp and everybody thinks it's cute, and then you look, but they're also presenting with, and you label it phonological disorder, go see speech therapy. But if you don't have a speech pathologist that understands myofunctional therapy and how that ties in with everything, I I have had just these beautiful stories, families that come in and then all they needed was to have these tethered oral tissues addressed, and the child has their voice back and everything
It's
comes
so
into
sad.
line. And I know,
Yeah,
yeah,
it's so
would you tell the story about the child with Soto's syndrome?
Yeah, it's a great story. I think I was relatively, a few years into treating tongue tie and also treating special needs. We had a way that we did that, and so this one came in, and he needed to first have sedation in order to get everything status quo because he had a lot of dental issues and so we like to get them settled. And so he wasn't a perfect one. In his case, we didn't send him out for all the stuff ahead of time because we had him sedated and I saw the tongue tie at that time. So in that circumstance, you make the best call you can per patient. And I went to ask the parents rather than doing another sedation. He only had 5 or 6 words prior to the surgery. And I said, do you want to do, the tongue tie today? We can do it. And I didn't know it at the time, but later when it was like in the New York Times or wherever, they were Googling tongue tie, but they also knew me and trusted. They're like, yeah, okay, go ahead. So he was speaking in full sentences that night. And it was just, yeah, it was really powerful. And that after that happened, I had so many people call, which kind of, is a little bit of a different topic, but it broke my heart because from other countries, parents would call. And what I was hearing was that they were being dismissed sometimes when they felt like their child had a tongue tie, especially when there was a special needs component to it, autism or other special needs. I felt like that they were being told by healthcare providers, like, your kid has X, so why do you even like just leave them alone? Why even bother?
Yeah.
But,
Yeah.
everybody should have the right to have the best airway that they can have,
Yes.
speak, breathe, eat, and all that kind of stuff. But that opened up a whole another world for me of like just feeling so much compassion for what people were going through.
Yes.
But yeah, I've seen plenty of stories. I've had moms call me the next day and, oh, he said mommy for the first time or this, that. There's like just so many wonderful
Yes.
stories that come of it when it's done and
Yes.
needed. Yeah.
I'll never forget, I saw a little girl, well, it's been probably about 7 years ago, and I was newer to my functional medicine practice, even though I'm an older practitioner. I've been a pediatrician for, 36 years now, and I just didn't know what I didn't know. And you kept bringing up IBLBC, and that's a lactation consultant for the listening audience. But I learned about tongue ties when I used to work for Texas Children's as a pediatric and newborn hospitalist and learned procedures. And now I'm like, oh, I learned the wrong way. You just cut it and go. But I will say that there were some really lovely stories. The mom goes, wow, this is great. My baby can suck. But one thing that broke my heart was this little infant, and his parents were bottle feeding, but he was so restricted, the formula just ran out of his mouth. And, there were obvious things that we could do, but also if you don't consult a pediatric dentist, ear, nose, and throat doctors will go, well, there's no tissue, I can't cut, or I can't do anything here. Would you care to explain what potentially like a submucous tongue tie or restricted tethered oral tissues and how you deal with that with the whole picture if you don't see anything that you could do something to? How would you assess that, Amy?
And I will say there are some ENTs who are now, really learning more and doing that. So I think your question is when the patient has all of the signs and symptoms of tongue tie, but you can't really see a frenum. And
Correct.
again, to me, I know that there are people who are really well known in this country who would say, I just cut, and you can kind of go in there. And the thing about what we've just been talking about, Paula, is that you made a difference in some of those babies' lives, and we can't really know, right? I mean, my first infant tongue tie, I was working in a surgery center and I used electrocautery and I just, doop, and that mom was like, oh, I have no idea what happened to him after that. But yeah, we do what we know. And sometimes even when we didn't follow all the best guidelines, good things can happen, but terrible things can happen too. So with the
Yes.
submucosal, yeah, I would never cut on it, but that's when I would come in with that non-invasive laser procedure and using that or a body worker. So basically that non-invasive laser procedure is doing something that body workers can do, like chiropractors and osteopaths, and they're getting in there and finding out, why is there nothing visible here, but the tongue is usually planted. It's like anchored to the floor of the mouth. So that usually means there's something upstream or downstream going on that's causing that. And we want to release all the adjacent tension and get things more ideal. I have a presentation, a lot of presentations that I give, but on this one in particular, I actually show how it looks at one when they first come in, and then we do the procedure same day. You can see the frenum, and then we sometimes have to do it several times, and then that frenum is crisp and clear and easy to see. And that's the only time when I would assess and say, yes, this needs to be cut or not cut. But you want to address that. You want to look deeper into that when you can't see the frenum and the function is so low. But it's good that ENTs would cut in that situation. Sometimes people do cut,
Yeah.
like they just kind of
Yeah.
push everything down to get a view of it and then sort of go right there and hope for the best. But that's almost always going to be a situation where the healing is poor.
Yeah. Well, and when I think about how much more important it is for a dentist to assess, because an ENT isn't necessarily thinking, unless they're trained, how the tongue sweeps and can get back to the teeth and clean the teeth and what we do with our tongue. I love what you talked about the glymphatic system of the brain too, because I think it was 2014 they were able to image that. Gravity also helps pull all that debris and garbage out of the brain while you sleep and making an airway and having optimal breathing there. I also had a little girl who came in. She was anxious. She couldn't really speak very well. And the parents were really concerned. They thought she seems to understand what we're saying and she'll follow instructions. But I said, in the first few minutes I assessed her, I went, oh my gosh, you see this right here? She has terribly tethered oral tissues. And then she went and had her airway addressed by a pediatric dentist. And the parents were like, you gave our daughter her voice back. And you've had the same thing happen. It's just a beautiful thing. I would say too, Amy, what you said about the children that we see who have profound special needs. And I see the same thing in the autism community. And, when you're a parent, you love your child more than life, and you would do anything within your ability to help them regain as much function. And when you're given the message, get your affairs in order, you need to have things taken care of. So when you're not around, who's going to take care of your child? The only evidence-based therapy is applied behavioral analysis. Ignore diet, ignore all these other things, and they just don't follow what would be reasonable medical standard of care to address, like you said, something as simple as an airway and tethered oral tissues to provide form following function. You improve the function and then the form corrects itself too. What about the ALF? Can you just briefly we've talked about all kinds of things, but you mentioned it. What happens when we throw static braces on the mouth? But let's talk about the airway and the palate and what an ALF
Okay,
is.
I'd love to. I want to mention just a couple more things before we jump off of that. And one just came to my mind when you were sharing that, and that is just to let families know that there is a brain to tongue pattern that starts in utero. And sometimes there's a issue with the brain to tongue pattern apraxia as an example. And it's often misdiagnosed or undiagnosed. And an apraxia child getting a tongue tie release without the proper preparation can be a really terrible situation. So I just wanted to mention that. And then I know at some point you wanted to talk a little bit about lips and buccal ties. So I just don't want to forget that that's part of what you
Mhm.
wanted to share. I'd love to talk about the ALF. So
Well, before you go on to the ALF, can you explain what a lip tie up here is, how significant it may be or may not be, and then what buckle
yeah,
other ties may be?
yes, I would love to. So with the lip, most of us are born with what we call a class 4 or a class 3 insertion. And I wish I had pictures, but if you lift the lip up, you can think of it like you can see mine, kind of personal, but see the little string up there?
Yeah.
Okay, so that little string, when it attaches all the way to where the gums stop and there's no teeth, and even wraps around, that's what we call a class 4, and that's pretty typical. And then class 3 is it just kind of goes to the edge but doesn't wrap around. So almost everybody's born with that insertion pattern. But I haven't
Mm,
had this talk in a while, but a huge, I want to say 3 out of 4 or a higher percentage outgrow that by the time the adult teeth are coming in. So from that standpoint, it's pretty normal to have a low lip attachment, and it's not necessarily something to worry about. When we're looking for a restricted lip, also a lip is not generally going to cause speech or feeding problems. It can like impact a little bit, but it's not going to be like the tongue. However, when it comes to nursing, let's say for example, when I'm assessing, I'm trying to see, can I hold the lip, not when they're screaming and crying and all tight, but kind of playing can I hold it and bend it back and can it flex to do that? Even if it looks thick and ugly or whatever, like, can it move? Is it supple? And so what you're looking for is, can that lip invert and go onto the nipple or the breast or the bottle so that they're not leaking milk? And if they can,
okay.
then I wouldn't do a surgery on them because I
Got
know that
it.
most of them are going to outgrow it later. The second time the lip might become an issue, let's say it did well and they're doing fine, the baby teeth come in and it's a really thick one that goes through. And again, this isn't the lip that's the problem, but if they're having a lot of processed foods, this is an area that can very easily get cavities with thick frenum kind of in the way, but they're typically doing other things that get cavities in other teeth. So if I'm having to restore cavities and there's some demineralization or issues here, I'm going to want to release that lip at the same time.
Okay.
And then for the buckles, these we have like 7 attachments all around, but the 2 that sometimes can become an issue is also here. And again, most of the time when you pull the lip out on an infant, that attachment is going to go pretty low, right? But what we're looking for is tension. And these are quite different than the lip or the tongue. And something that I learned from working with body workers, really good ones, this is actually the end of an entire fascial train that runs right through the sternocleidomastoid. It's impacted especially in torticollis and plagiocephaly babies. So you can sometimes release this one and have a whole change pretty fast. However, I prefer working with a body worker who like gets them really ready for that because if you release it and all of this hasn't been addressed, it'll just tighten right back up because you're going to have a frenum. So if it's in an appropriate place and it's not real supple and moving, it can affect the way they swallow, the way they eat, holding, milk leaking, things like that. But just cutting it, it can form and be tight again, even though it might be a little higher up. So again, the point is body worker doing all that they can do to release the tension because our fascia, we're connected from head to toe, our tongue is connected to our toes and all that. So this is very commonly associated with babies with preferences, torticollis, and things like that. And if you have a baby with torticollis, do not release the tongue tie until they have had a green light from body worker.
So torticollis, would you let everybody
Yeah,
know what that is?
that's after 8 weeks of life, your baby should not typically have a head preference where their head's more often one way. And then torticollis, it can be at birth, you can have it as an adult, but it's basically where things are kind of twisted and tilted and the baby tends to be down and to the side more often. And when you check them, like if you lay them on the back, you roll them one way and they're fine, but when you roll the other way, they can't even really lay their head flat. So that is again, babies form from head down. And sometimes, especially if a baby's had like a vacuum birth or these other kinds of birth, that creates patterns in the fascia that go throughout the whole body, torsions and things like that. And so that can show up in the rest of the body and function. And those things really need to be addressed before you start cutting any tissues, even if it's an anterior tongue tie. But you will have times where a body worker says, okay, Amy, like I've done X, Y, and Z. I've gotten the baby as far as I can. I need this released now. And then they go right back in and are working with it. Otherwise, it can get restricted again, so to speak.
Mhm,
And
mhm.
one other thing
And
on that,
then
Paula, is just to mention is that I always tell families it's not hard to do a tongue tie release. And so I would get a lot of reconsults like, oh, doctor so and so may have not done a good job or whatever. Anytime you've had a tongue tie surgery, I always assume it was done well and right the first time. And my first thing is let's figure out what's going on and caused it to either scar down and heal poorly. It's not really a reattachment because the fibers are ablated, but like, why did it heal this way? Figure that out. They have a second and then a third and even a fourth surgery and, oral aversion and trauma and all of that.
And we had just briefly, it's multifactorial why it could scar down like that. One thing when we do our wellness blueprint, I had mentioned that is we identify something called tumor necrosis factor alpha. And if that doesn't work appropriately, there are things that you can do to optimize lowering the inflammation in the body. But as you said, it's all these things all together. I love what you brought up about because it also makes me think about headaches. It's headaches in children. A child should never have a headache. But when we think about cranial torsion and the way things, just recently, Dr. Cheng Ran, who I know you know Dr. Cheng very well, that looking at patients with connective tissue issues, Ehlers-Danlos, and how that feeds in, and then what can happen to the fascia, as you say, fascia, tomato, but how the cranium, when it is distorted, and then, you don't know what you don't know. You don't know until you look at somebody and their shoulders riding higher than the other, or you put your hands on their hips and one leg's riding higher than the other. And I'm like, my first stop, go see the chiropractor, unless it's a terrible scoliosis. It's game over at that point in time. But it's like, body workers are it. I mean, they're fantastic. So now
Yeah.
tell us about the
Okay,
ALF.
that's a great segue. So my really good friend Tasha Terzo, she wrote the Alpha Approach book, and that's a great book if you're curious about it. But she has a video where she'll show a crossbite and putting you might want to do this in your practice. You put a tongue depressor between the teeth, so you disclude them, and then you have the patient lean back over. And sometimes there's no scoliosis. It's actually stemming from the teeth.
The mouth.
Yeah. There's her
Wow.
passion is
Wow.
teaching osteopaths to go inside the mouth, because if they treat a patient and have, "It's all good," and then they get off the table, bite their teeth together and walk, and they're like, "Back in the office again," they're missing something here. And she teaches dentists to not just look here, but to look at the rest of the patient. And that's a great segue into ALF, because so ALF really follows, in my mind, there's kind of two approaches, which is what I talk about with families when I do. There's the traditional approach, and then there's this, less traditional approach, which is more osteopathic. And osteopathic philosophy is that everybody has everything they need inside of themselves from the time of conception to be their best self. And our goal is to sort of just like get connected with their system to see if there's any barriers. A tongue tie might be a block or a barrier, and then to enrich the environment, like which is what you do with all these supplements and things that we take in our family that help with what we're genetically predisposed to, minerals, whatever, all of that stuff. So ALF is really looking at the whole patient. And then when you're talking about expanders and appliances that cross the midline, sorry, yes.
Can I ask you, what does ALF stand for?
Yeah. Actually, several people say different things, but it's advanced light forces type of appliance. It's just a functional appliance that's made with a really light force wire that resonates with the natural motion of cranial motion. So an alpha
Okay.
appliance increases cranial motion and it mimics some of the things that should be happening anyway and helps you to get there to where you're creating that motion. So traditionally, braces, Invisalign, expanders, like all of these appliances that cross the midline and sort of lock on, they inhibit cranial motion. So what you can think about is if you had a patient that had asymmetry in any part of their body, it's because some of the fascia is moving and some is restricted. And then you put an appliance in and you're like, okay, they need to be this wide. So you start that widening process or whatever you're doing. Every action has an equal and opposite reaction. I can't change that law. That's true. And so the part that is it's mobile will move and change. And you can't see this with your eyes, but I have shown when I teach dentists, like, and you see someone will post, like, look at what I did to the airway. And they'll show the face picture and then the side picture. And they're highlighting this tiny part of the airway. Like, look how much bigger it is. What I look at is like, oh, we had a natural shape to the upper spine in the pre picture. And here's what our face looked like here. The post picture, we have no more curve in the upper cervical because we did this force that pulled it out. And if you measure, the patient's more asymmetrical than they were to begin with. That doesn't happen to every patient, but that is what can happen. And to me, that's again about that what we talked about at the very beginning of the other podcast is it's like me looking at you and saying, okay, let me do some calculations. Da, da, da. The first step that orthodontists used was based on one white kid during the time of eugenics or whatever. And he
Mhm.
wasn't even like healthy. So it's like me going, no, see, we need to do this and that. Let me put the right forces in and let me get going. And I'm forgetting that what I'm doing here is affecting the whole rest of the body. So ALF is different. ALF is such a light appliance. It's not meant to be used as an expander. It's not an expander. And sadly, when dentists start using ALF, if they don't have enough training and if they're not able to kind of step out of this mechanical paradigm, and they start using it in the same way that they would use the other appliances. They get frustrated. They tell their patients it doesn't work, all this other stuff. But ALF, you place the ALF, the designs are generally very simple, especially in pediatric patients. The first thing it does is creates more cranial motion, which is why sometimes we see miracles right away. It creates the motion similar to what the tongue would be doing, which aids in lymphatics. It draws the tongue like a magnet up to the roof of the mouth, which is why in a well-placed ALF and in a patient that's got what they need to have going on in that care, sometimes the first month nasal breathing, sleep changes, bedwetting stops, that can happen like really, really fast because it's nervous system things that are changing. And then the general summary of ALF is that the ALF, again, is not making the changes. The ALF is helping the patient's tongue to come up, to start functioning properly. The tongue is the driver of growth and development. Proper function is the driver of the face coming forward. And so ALF patients at the end of the day are more symmetrical. Their faces have come forward and wider. Their shoulders, when I'm done with the case, shoulders are good. When they're to the side, I want shoulder, TMJ, shoulder, hip, knee, ankle all aligned in that view. Yeah, we want the breathing well, sleeping well, and that's what you get. But you're doing it in a completely different approach, if that makes sense.
Yes, yes. So I really appreciate that explanation for everyone who's listening that there's alternatives to what you can do that it allows the body to function and move the way it's supposed to. So, well, Amy, I'm so grateful for your time today, and you've really equipped our listening audience with some excellent pieces of information and encouragement, and really drove home how important it is that the body needs to be functioning very well before you go in and do anything surgically or by laser. And I kind of refer to that as a surgery, to loosen those tethered oral tissues. And man, we could really learn something from Brazil
Oh,
too.
yeah, absolutely.
Uh, it would decrease the cost. This is kind of the way I look at our precision genetics too. It's like if you could, if if I had known how my body worked and what I needed and what I didn't need, so many things that had happened would not have happened. But hindsight's 2020, and we have these gifts, these blessings. Now, before we go, would you please let people know what's going on in the Houston area that is a new passion of yours?
Yeah, I have to tell you this before I do, because I know you can edit it out, but your precision genetics have helped our family so much. Like my nephew who had the gene for celiac, and we knew since birth.
Yes.
And so I know that changed his life. And then my own daughter who has had, impaired autophagy and these other things that you shared with us have helped us. I mean, and like I would have given her collagen and that makes her crazy and just other simple.
Yes.
So I'm just so grateful for that. We loved working with you with patients because when we knew they had that TNF, we approached things quite differently from a surgical standpoint.
Yeah.
So
Well, I really appreciate hearing that. And, for our listening audience too, when we think about what she said, collagen, it's about another genetic finding called GAD1, glutamic acid decarboxylase 1. And we think collagen, amino acids, let's do that, vital proteins. Well, if it's got a lot of L-glutamine, because L-glutamine is something that helps the gut, well, for a lot of people, that's fine. But if you give it to folks, same with bone broth or chicken bone broth versus stock, bone or chicken stock, it makes you nuts and anxious. And you're like, this is supposed to be helping me. What's wrong with me? So
you have no
thank you
idea
for
it's
that.
great and your kids are just a disaster and like, yeah.
Yeah. Yeah.
Appreciated that information.
Thank
Yeah,
you.
so I'm opening a new practice, which I'm excited about. And I'm opening a practice that's just 0 to 3-year-olds because that's where I feel like there's a lack of providers that are able to kind of look at the whole patient and help get the team together and really help that population. So I'm excited about that. Also, something that I learned in my practice is that oftentimes when the little ones coming in and they're struggling, the parents are struggling a lot too. And we kind of talked about this just guilt, the birth trauma, the not being able to breastfeed, all the different things that happen. I remember my husband, when Evelyn, when I was trying to feed her, and he's like, I thought this was supposed to be natural. Like, just like, shut up, I can't do it. It doesn't feel natural. But so all of that's happening and there's stress on the parents. And so I have another business called St. Tora that I've been working on, and I've decided to kind of open them in tandem. And so what that means is that when families come and I'm able to support them with their babies, I also have, some people call it biohacking, but it's biotuning technology, and it's a way to help parents kind of come back to center, to empower them. Some of it's just as simple as grounding or, a variety of things that, are free if you want to do it out in the world. But it's just helping parents to have a space in that same place to go and use different pieces of technology. We'll also have breath work and meditation support and like people like you coming to speak to our families and supporting them in that way, kind of like a little support group. So I'm really excited and hopefully that'll be the first quarter of next year. And yeah, I'm really grateful to be stepping back in this new way after a little bit of a sabbatical.
Yes, and I just think the whole vision of helping mom and dad and the rest of the extended family, because it's true when your child is suffering in any way at all, or something as basic as being able to feed them and nourish their bodies, and then a woman feeling totally inadequate because they're having trouble. I remember with my firstborn, and here I am a pediatrician, I ended up having a C-section, which I never thought would happen. First of all, strike number one, it never even, crossed my mind. And my mom, who had never breastfed, I'm there trying to get my baby latched on. I have massive breasts and I'm trying to get her latched on. And I feel so inadequate. I'm tight. And I know when I meet mamas here, it's like, okay, let's get you all propped up and comfortable and some pictures or pillows. And if I had just had that help, it would have changed everything. It would have changed everything. And the moral of the story is I had one more C-section, and then by God's grace, I was able to have two VBACs after that. So, even though they say no more, it's like you can sometimes sneak them in and it's a
What
blessing.
Paula, I
So,
would say to you is that again, we all have this thing we come here to do, whatever it is, we don't know.
yes.
And if you had not had those experiences, you may not have had the compassion and the passion to pursue what you have and to help so many moms and kids. So
I think that's a beautiful way to wrap up the podcast that people who are passionate, like you said, when you were 18, you didn't know what you didn't know and you had dental phobia. And it's true. It's like when we've walked through what our patients have walked through, we're able to be loving and compassionate and kind and respectful and honorable and meet them where they are. So, and that's the epitome of what the core of functional and holistic medicine is, addressing who we are spiritually, emotionally, mentally, in order that all those other downstream things flow from there. And that's exactly what your vision is, I believe, addressing those core challenges, the body trauma that affects from the inside out. So, again, thank you for your time. This has been so fun, so informative, and I can't wait for our listening audience to be blessed by what you have to share with them.
So much. Thanks for inviting me. I really appreciate it.
Thanks for joining us at Get to the Root with Hope for Healing. If this episode helped you, follow and share it with someone who needs it, and leave a review. It helps others find us too. For a free consultation, visit our website at gettotheroot.com with the number 2 and schedule a welcome call. We'll see you soon.